Welcome back to Navigating Cancer. Again, I'm Dr. Joey Bennett, joined by Wendy Hall, and our topic today is breast cancer. In the first segment, we went over a lot of the risk factors and things of that nature, and in this segment, we are very happy to be joined by Dr. Mark Fernandez. Dr. Fernandez is a general surgeon at Invergis Surgical Associates. He's been here for coming up on 17 years that you and I have had the privilege of working together. We've always taken a very good team approach. We communicate very well, so we've asked Dr. Fernandez to be here with us to talk about some of the things we can do as far as looking for breast cancer, and if we do find a breast cancer, we're going to talk about the options of treating it, especially the surgical options, since we have a surgeon here, and every surgeon will tell you that you heal with steel, so that's what we're here for.
That's what we like to say.
That's what we like to say. So go to the next slide, and we'll look at some of the recommendations that we got that we want to show you. These are the American Cancer Society recommendations, and they haven't really changed despite some controversy. You want to have mammograms beginning at the age of 40. And from the age of 40 to 50, every 2 to 3 years, have a mammogram. If you've got a really strong family history, you may want to start those a little bit earlier. But one of the other things that you see on this slide that I think is very important is self-breast examinations and examinations by your primary care physicians as well. I mean, I think you would agree with me that that's one of the things that probably women don't do enough of.
Absolutely. I wanted to speak to that. I can't say how many patients, more than half, I'll say most, that they say, I say, have you found anything? Have you noticed any symptoms? And they say, oh, I don't bother with that. And I really try to stress that they should, because mammograms miss 10 to 15%, which is a high percentage. And if you just do a simple exam once a month, you're going to pick up a lot of findings.
Right. And on the next slide, you can see kind of what options we have as far as the diagnostic tools we have. First and foremost, absolutely, is the mammogram. I mean, it has really made a dramatic difference in the cure rates for breast cancer and the early detection. Number two is breast MRI. It still is used rarely, I would say, compared to most of the technologies that we use, partly because of the cost, but also because sometimes it sees things that aren't really real, that can be way too sensitive for that, and it's very expensive. You and I have to fight insurance companies all the time to try to get the MRI done. And the last two that we see that were on that slide, again, comes back to the breast self-examination and the clinical examination. How often should women be examining their breast?
They should examine their own breast once a month, you know, however you can remember to do that, either the first of the month or when the phone bill comes, or, you know, whatever thing reminds you to examine yourself once a month. With the other exams, don't forget ultrasound. We use that. Mammogram's far and away the most common tool. Ultrasound is frequently very useful. MRI is rarely useful. A lot of people ask about it. It's not something we use commonly. It's not mainstream. But on rare instances, it can be helpful.
And I think that the exam is so critical, because you and I see patients when we follow them up, or if you see them, we may examine these women twice a year at the most, and you and I seeing as many patients as we do, we honestly don't remember every little detail, and nobody knows your breast better than you. So it's that self-examination, get in the shower or the bathtub, soap up your breast, feel of your breast, because you will know it better than anyone else does. Realize that if you're still having menstrual periods, your breasts are going to change during the month as far as tenderness and size and things of that nature, and sometimes cysts can change along with their menstrual cycle, right?
Yeah, absolutely. And that, it's, as we examine it maybe a couple times a year, I'll say, hey, if I feel a lump, you can go, oh, that lump, been there 10 years. But this lump over here, been there a month. So they can really help guide us on what we need to do.
And shouldn't ladies also look at themselves visually too? Because I know you don't normally, sometimes you can't feel it, or you can't.
That's part of it, where you look at your breast in the mirror. You can put your arm up over your head and look at the breast. You can look at it from different angles to see if there's any skin dimpling or any change.
I just wonder if ladies should be advised to do that, because maybe that would be more routine,
Well, I think it is something, because if the ladies are watching, will stand in front of a mirror and just raise your arms above your head, your breast should kind of change in the same way. And if you notice that one goes up further than the other one does, it may be a sign of something in the lower part of the breast, kind of keeping it from going up. So I mean, it's a great point to do that too.
Dimpling, yeah, one of the more common things you can find is a dimpling of the skin or some change in contour.
Right.
So.
We're going to show you a couple of pictures of what we've been talking about, at least on two of these. The first one is actually what is a mammogram. This is just a conventional mammogram, and you can see on the left-hand side of your screen is the mammogram machine. On the right-hand side is an actual view of a mammogram, and that bright white spot that you see on that mammogram is extremely suspicious. The breast, again, is mainly fatty tissue, and breast cancers tend to be more dense, so they light up like that. If you can show us the next slide, Bill, gives you a better idea of how some of these densities can look. And a critical part of a radiologist reading a mammogram is consistency. It's seeing what it looked like from year to year to year, because some women will have denser breasts than others, and it's critical to have a series of mammograms to look at as you go through and watch them.
As another thing that's very important is digital mammography. There's old-timey mammography. It's really the difference between a Polaroid picture and a 10 megapixel picture. You're going to get a much better picture, far more detail with digital mammography. So I think everybody should be getting that now.
In ways that the radiologist can actually manipulate the image. You know, if you've got a piece of x-ray in front of you, you can't manipulate that, but those of you with digital cameras and computers, you know how you can change the views and let you see things a lot better. Next slide is the MRI, and you can see that you get really great detail of the breast tissue, but again, there is that bright white spot that is showing up in the breast, and that's what radiologists would look like or look for. And if that's seen, the next step is for your primary care physician to be referring you to a surgeon for evaluation of a biopsy. And on the next slide, we've got an idea of these are the treatments. You know, breast cancer surgery is or breast cancer treatment is a multimodality specialty. And the thing that we're very fortunate about here in Citrus County is that the surgeons, the radiation oncologists, the medical oncologists, we communicate very well, we talk about patients, and we try to optimize the treatment that's right for them. But you're looking at surgery, you're looking at chemotherapy, you're potentially looking at radiation therapy and potentially hormone therapy as well. And these all depend upon a lot of different factors when we actually do the biopsy. I mean, that tells us a lot to start with.
Absolutely. Some of this you can plan before the surgery or before the biopsy, and then some after you find out about lymph nodes and a lot of other factors. We get information, and we all work together, put our heads together, and decide on the best plan of treatment for that patient.
But you see on the next slide that we've got is it's the goal for our breast cancer center here in Citrus County is that we want to make this a combined modality approach with the surgeons, the radiation oncologist, and the medical oncologist, and then the other role are the pathologists. The pathologist and the radiologist provide us with a lot of information that's critical to us trying to decide what's the best treatment. They can give Dr. Fernandez information about the best surgical treatment. So when we come back, we're going to get into the surgical treatment and other parts of breast cancer treatment. We'll see you in the next segment.